Olá, meu nome é Rafael Brant, sou oncologista clínico do Grupo Oncoclínicas. Aqui ao meu lado tem a doutora Partridge, oncologista especializada em câncer de mama, diretora do Programa Young and Strong para o tratamento de mulheres jovens com câncer de mama. Hi, Dr. Partridge.
Hi, Rafael.
So first, I would like you to highlight the special aspects of breast cancer in young women.
Sure. So in young women, when they're diagnosed with breast cancer, especially at the age of 40 or younger, they're more likely, as you well know, to have more problems both emotionally and physically over time. And that's because, in part, they are more concerned about things like fertility, body image, sexual health. They also are a higher risk of being hereditary predisposition to breast cancer, having a genetic reason why they got breast cancer. And then finally, from an emotional standpoint, they tend to be less resilient. They haven't been through as much in life. And they tend to have more aggressive cancers, and they get more aggressive therapy on average, which can be appropriate, and therefore it can be beat up a little bit more than your average breast cancer survivor. So it's really tough for our young patients, but we're doing more and more to support them, so I'm optimistic for them.
So tell us a little bit about your Young and Strong program. Do you have that back in Boston?
Sure. So in about 2005, we started a program in the Boston area at Dana-Farber Cancer Institute that focused on the unique issues facing our young patients. And it's an umbrella program where we invite every young patient to be a part of it. She's welcome and enrolled no matter what, unless she tells us not to bother her. And it helps to support both the patient and her providers, the doctors and nurses, to make sure she gets the care and the resources and programs that she needs that may be beneficial for her. So we have things like a telephone support group for our young patients that we roll out through the program. We help with referrals to things like a social worker or a genetics counselor or a fertility doctor. And we also have programs that we run on a regular basis, like workshops around sexual health, or survivorship evenings, or a day-long forum where we bring the women together to meet each other and bond with each other and find some communal experience together, because women love spending time with each other in their survivorship and learning from each other. Not all women, but many, especially the younger women, because when they look around in the cancer clinics, even though we have a lot of young women, and I know you have a lot of young women too, they're still likely to be the youngest person in the room and not feel like there are other people there who are just like them. But when you bring them together, they look around and say, oh, I'm not alone, and there are things for me, designed for me, and I'm going to get through this too, just like her.
And from what I understand, the key of the program is information, and we have a lot of misconceptions among physicians about pregnancy after breast cancer. So how can we tackle this problem? And I'd like to talk to us more about your positive trial.
Sure. So there are a lot of misconceptions around breast cancer and breast cancer in young women specifically, and that's in part because it's more rare than in older women, so people don't know quite as much. And we're trying to change that with data we're collecting and research we're doing around our programs. And I'm excited to do the research here in Brazil with you as well. But around pregnancy, we know that big studies where women have gone on to get pregnant and some women haven't. We know that it does not appear that the women who get pregnant after a breast cancer do any worse than women who don't get pregnant. They seem to do just as well. They're just as likely to survive through and beyond their breast cancer. And so with that information, if a woman comes to us and says, I want to have a baby after breast cancer, we say, okay, how high was your risk? How risky is it, your cancer? Because even if the pregnancy doesn't make your breast cancer come back, we don't think it would, it's still a possibility that it could come back. So you have to weigh that with the woman, and you also weigh the timing. So if a woman needs to take hormonal therapy, for example, and the majority of young women have hormone-sensitive breast cancer, then you want to get her through as much of the hormonal therapy as she's willing to take, and allow her also to not wait 10, 20 years to have a baby, because the time is ticking there in the biologic clock. And so sometimes we preserve fertility, sometimes we help women to take a break from their hormonal therapy, sometimes we recommend they take the full 5 years, especially if they're very young, or if they banked eggs or embryos before their treatment, then they can go use those. But for the women who really want to have a baby soon, and need to get hormonal therapy, we've designed a study called the Positive Trial, which is open worldwide, and it is designed for women who are really anxious to be pregnant but want to take some hormonal therapy. So women take up to 18 months, no less than 18 months, and they can't have taken more than 30 months in a row. And then we enroll them in the study. They come off their endocrine therapy, try to have a pregnancy, hopefully are successful, and then get back on the hormonal therapy to take whatever duration had been recommended or they choose to take moving forward, 5 to 10 years being a standard. And we're looking at how those women do in the long run, and we're going to compare them to women who have been treated in historical control groups or in the text and the soft trials, for example, and see if they do just as well. We hope they do. And we're also going to look at the reproductive outcomes. How hard is it to get pregnant in women who've been on tamoxifen for a couple of years or in women who got chemotherapy? And then finally, we're going to look at how they do emotionally. You know, how important, we know that having a baby for some women is the end all be all. On the flip side, how anxiety provoking is it to come off your hormones? You know, is it the right thing? And how can we counsel future patients based on the experience of the women participating in the Positive Trial? So we're looking forward to seeing that data in the coming years.
And about systemic treatment, you know that young women don't stay on and don't have much adherence to treatment as the older counterparts. So I would like to summarize in the special aspects of systemic treatment with in young patients, and how can we stimulate them to stay on treatment.
Right, so it is a big issue. We know that adherence, persistence, or continuation of a therapy matters. Drugs don't work if you don't take them. And so we have to, I think, shine the light on it in our own practices. It's okay to have a conversation with your patient and say, how's it going taking your tamoxifen or your aromatase inhibitor? How are you tolerating it? Do you have a hard time taking it? And I'm always surprised when I ask that question, how many people answer me, yeah, some days. And honestly will tell me, and then I say, well, you know, tell me what gets in the way of your taking your tamoxifen or whatever they're taking. And often it's, you know, I don't like the way it makes me feel, or, you know, sometimes it's side effects, so I try and troubleshoot the side effects. Sometimes they don't even start because they're afraid of side effects or they're angry and upset about their cancer. And, you know, especially for some of the very young patients, it can be a little bit of a rebellion and an anger thing where they don't take their drug because they're angry that they got breast cancer. And then they blame the, you know, misplaced anger on the drug and kind of not taking care of themselves. So sometimes it's worth having the conversation to say, you know, tell me what's going on there. And when you pick it apart, people don't want to hurt themselves. They want to beat breast cancer, and especially if they're tolerating it okay, sometimes reframing it and saying, you know, I've had patients tell me that they call their tamoxifen their power pill, and that the breast cancer is the enemy, not the tamoxifen. And I try and help women see that in a kind way and help them to feel empowered to take their tamoxifen. I say, you know, I know you don't like it. I wish you never got the breast cancer, right? That's the enemy. Let's focus on what we can do to make sure that you never have to do anything more than take the tamoxifen. And if you're really suffering from side effects, that's one thing. Let's make that better or switch you to something else. But if it's just anger, fear, these are big things. Oftentimes I'll also get a mental health provider to help if someone's really suffering. But you can do a lot of work around kind of helping a patient to kind of unpack what's going on there once you figure out that she's less compliant or is afraid to start the tamoxifen or has stopped it. And for some women, it's just intolerable, and we have to say, look, she's going to take her chances. I don't want to be nihilistic, and we try different things. But we have to be careful not to make people feel badly and therefore kind of not tell us stuff or run away. Because we know that, you know, doctors want to hear stuff, but if it's not happening, then we need to know what's going on with our patients so we can help to navigate them as well as possible.
And I know working with young women is something very close to your heart. So I'd like you to share what that made a difference in your practice, in you as a doctor working with the young women.
Yeah, so it's a real privilege to care for, you know, all patients, as you know. And the youngest patients, for me, really pull on the heartstrings because when I started doing this, I was a young woman, but my empathy has grown even more as I've gotten more experience and as I've grown more mature. And I think it's just such a hard thing to be diagnosed with a breast cancer, period, for any woman. But it does feel much harder for the very young. because of the timing of where they are in their lives, both from a career and school and young marriages or young families, or not even being involved with a partner. And there's a group in Canada called the Young and the Breastless. It's really hard, and trying to help them through that time beyond just treating the cancer, but supporting the patients, for me, is very, very gratifying. And I learn from the grace of my patients every day and how strong they are. And that's why one of the reasons we named our program Young and Strong is that the women and their partners and their children and their mothers and fathers, they all just rise to the occasion most of the time. It's hard, and there's some moments, but everybody's allowed that. But it's just incredible to me how people can kind of rise to face the adversity and get through it. And to me, that's the most gratifying and the most exciting. And also to watch, the way that our treatments have improved, such that we now have information that we can tailor care better for our younger patients and spare them some things and know when the right tool for the job is, chemo or not, or give them the better hormones rather than something that may not be as good for them. So I really have loved to see it along my career path so far, to see how it's evolved and how we care for our young patients too.
All right, Dr. Partridge, thank you so much.
Thank you. It's been great.